Presentation number 18, GIT, liver problems solved by MRI, prepared by Prof. Sharaf and revised by Professor Hani Sami. "45-year-old underwent CT abdomen, and we found this area. There is unrelated. The patient came for unrelated liver complaint. This hypodense area with contrast and still hypodense. It's not a cyst. And here in phase and out of phase, we found that fat is delineating the liver and loops as dark, and at the same time it appears here as low intensity. A 2 cm hypoattenuated area is seen by contrast. The liver using chemical shift in phase and out phase, showing signal drop black in out phase, denoting fat component. This confirm fatty liver infiltration. Case 2, a patient with known melanoma and initially diagnosed as metastasis. We want to know whether this is hamartomas, biliary hamartomas, cysts, or metastasis, and the diagnosis is multiple cysts. The lesion all showing intensely bright signal in T2, in heavy T2 weighted images, and no enhancement on post-gadolinium T1 weighted images. So they are not deposits, they are biliary hamartoma or multiple liver cysts. Middle-aged woman in whom an incidental liver lesion has been found during an examination performed for unrelated condition. Focal hepatic lesion have atypical ultrasound and CT appearance. In contrast, it is seen enhancing. Portal face CT scan shows homogeneously enhancing lesion within a halo of a slightly increased attenuation. There is an ill-defined margin similar to this seen by ultrasound. An echo-poor lesion lying within a halo of reduced echogenicity was incidentally seen at sonography, confirmed by CT as a homogeneously enhancing lesion with poor defined outer margin of increased density. In T2 weighted images, it is markedly intense. In phase, T1 weighted images is low. In T2 shows nodular. In out phase shows again low with halo zone around. So we are dealing with something fatty, and the liver as a whole is blackened, denoting fatty infiltration of the liver. So we have something fatty first. Now, is it benign or malignant? We need biopsy or not? The large lesion is a hemangioma, as it is seen here, and intensely bright in T2 weighted images. So it is a hemangioma in a fatty liver, as it is proved by the out phase. And the smaller lesion is a small cyst, that one. Post-gadolinium, we have seen marginal nodular centripetal enhancement with the closing iris sign. Marginal nodular appearance with closing iris sign. So this is hemangioma in a fatty liver. A patient 65-year-old with previous colorectal carcinoma developed focal lesion. CT arterial, you have something starting to enhance, wants to enhance, while in the CT portal it fades away. With these two, we are dealing with something malignant. In phase and out phase is not fatty, as it is hyper intense in out phase, and with these two we are not dealing with fatty area, but we are dealing with fatty liver. The liver as a whole is blackened in out phase, blackened in CT, blackened in CT. So we have a deposit in fatty liver. So you should be aware of two items: the condition of the liver itself and the condition of the lesion itself. If there is a lesion, search for multiplicity. Case 5, female patients with previous certain breast carcinoma. Sonography shows echogenic lesion in the right lobe. T2 weighted images shows both lesions are hyperintense. More in phase and out phase. One of them is intermediate and one of them is hypo intense in out phase, denoting fat content, but still there is something vascular inside, some soft tissue inside. It's not homogeneous. Post contrast 1, 2, early, delayed. Post contrast shows that one has nodular enhancement on the margin. With closing iris sign, we have centripetal enhancement, that's hemangioma, and that one is definitely hypointense, but there is vascular element enhancing inside, linear tortuous structure inside, denoting an angiomyolipoma. So we have angiomyolipoma. Now here we have multiple small cystic lesions. Among the possibilities, microabscesses or multiple deposits or biliary duct hamartoma, so long they are behaving like cysts in T2 and in T1 they are hypo, so hypointense T1, hyperintense T2, and hypodense T1 non-enhancing. These are simple cysts of biliary duct hamartoma. Another case, patients are asymptomatic in contrast to patients with liver deposits or microabscesses, and biliary hammer look identical to hepatic cysts, but the distinction is not crucial because both are benign. Are not large lesions which are seen generally in polycystic disease. In polycystic disease, we have larger cysts, more than 1 centimeter, and usually limited number of about 10 or more, as in Caroli. But here in multiple hamartomata of the bile duct, they are miliary, scattered, and small, very small, less than 1 centimeter. Now here, this is definitely fatty liver by CT, but still there are multiple areas of low density which are non-enhancing. There is no history suggestive of anything, no relevant history. Now going to the in phase and the out phase, we have the out phase showing the black character of fatty lesion and the black outline of fat. So this is nodular fat deposition. Here, in this case we have axial T1 in phase, axial T1 out of phase, and we have the terbospinico, the fast MRI. This one is black denoting iron, this one is black denoting iron, this one is not fat, this one is black denoting iron in T2 weighted images, and the same. The spleen is spared. Being spared, this denotes primary hemochromatosis. Here we have male 60 years, 14 months after radiofrequency ablation of 2 lesions near to the anterior surface of the liver, one here, one there. Is there a recurrence? CT showed a circumscribed hypoattenuation separate from the surgical clip on the anterior liver surface. There is surgical clip here causing artifact. This is separate. Is it recurrence? Now this is T1 and this is T2. Definitely there is something enhancing, and the region appears as hypointense on both T2 and post-gadolinium. The region itself is hypointense, but there is definite adjacent area of hyperintensity in T2 and increased enhancement in post-gadolinium. This denotes that there is recurrence of the lesion which is ablated nearby, juxta to the lesion, near to it, adjacent to it, there is an area of recurrence, and this area represents the effect of reduction. The patient with male patient underwent right lobectomy. There is definite defect here for metastasis. Focal fat or recurrent metastasis. There is here an area of low density, but the enhancement is minimal, no enhancement. This is the in phase and this is the out phase. In the out phase it is black. In the T2 star it is almost not seen. Here it is blackened, denoting focal fatty change. Mafia stress tissue interfaces. CT records X-ray attenuation. MRI can demonstrate several different tissue characteristics so that acquisition sequences can be chosen to enhance or isolate the features which are most likely to discriminate individual pathologies. Here the patient have coexistent cyst and metastasis. Thirdly, while contrast agents used in CT and sonography have extracellular distribution similar to that conventional MRI gadolinium, intracellular contrast agents are also available to use with liver MRI, giving an additional dimension to characterization of the two main cell populations of the liver, the hepatocytes and the Kupffer cells. Differentiation of the lesions with central scar. Central scar is fine nodular hyperplasia or fibrolamellar malignancy. these can be differentiated with the too much enhancement occur in early malignancy, which soon washed out, and here there is definite scar inside. As seen in inversion recovery T2 weighted images, while an equilibrium is reached in delayed phase. So MRI today can solve many liver problems. A comprehensive MR imaging examination including T2 weighted heavy T2 weighted images in phase and out phase, dynamic contrast with 3D gradient echo imaging, special MR contrast agents for liver imaging, characteristic features and enhancement pattern can be used to diagnose or at least narrow the differential diagnosis, detecting small metastases and differentiating small liver lesions. This is the effect of increasing the TE on focal lesions like hemangioma. Heavy T2 weighted images shows more apparent, more intense hemangioma. Thank you.